Hi everyone and welcome to the IR's virtual education. Today we're going to talk about biomarkers, risk factors and practice recommendations for perioperative neurocognitive disorders. Thank you so much for being here for this educational seminar. So there's no commercial support for this webinar. So IR's virtual education series has been planned and implemented and obviously is available to all IR's members. CME will be available and you'll receive an email at the end regarding that. Please join us next year in Denver, Colorado for the annual IR's AUA and soccer meetings 2023 in person. There's currently a call for sessions for the 2023 Denver meeting. These are open until this Friday is the deadline. So please, if you have a session you'd like to put forward, submit it by July 15th, this Friday. Q&A, please use the Q&A at the bottom to submit questions. And you will be able to continue the discussion on the IR's doc matter after the webinar. You will receive an email regarding CME credits for this session after the webinar. So today we're going to talk about biomarkers, risk factors and recommendations for perioperative neurocognitive disorders. We're going to start with myself. My name is Liz Everard. I'm Associate Professor of Neuroscience in Anesthesiology at Weill Cornell Medicine in New York. I'm Associate Professor at University of Melbourne in Australia and Scientific Head of Research at St Vincent's Hospital in Melbourne. I'm particularly interested in biomarkers and identifying at-risk individuals for perioperative neurocognitive disorders. I'm an associate editor for the British Journal of Anaesthesia and a senior editor for Anaesthesia Analgesia. Our second speaker today will be Professor David Scott from Melbourne, Australia. Professor Scott is the Director of Anaesthesia and Acute Pain Medicine at St Vincent's Hospital, Melbourne, and is a Professor, Director of the Department of Critical Care, Faculty of Medicine at the University of Melbourne. His current research focuses on outcomes, including acute pain and safety of postoperative opioids, patient blood management, and in particular, the neurocognitive effects of anaesthesia and surgery, especially cardiac surgery, with a focus on delirium and how inflammation may drive this and how multidisciplinary perioperative care may improve outcomes. He has been a cardiac anaesthetist for over 3 decades and is the Australian Chief Investigator of the transfusion requirements in cardiac surgery in younger patients, TRICS-4 study. He is a Chief Investigator on the national funded PROTECT trial investigating perioperative optimisation for improved cognitive outcomes. Our third speaker today will be Professor Stacie Deiner. Dr. Deiner joined Dartmouth from the ICANN School of Medicine at Mount Sinai in New York, where she served as Vice Chair for Research and Professor of Anesthesiology, Neurosurgery, Geriatrics, and Palliative Care. Her research expertise focuses on cognitive recovery in older surgical patients. In her clinical practice, she is a neuroanesthesiologist and had previously led Mount Sinai's Division of Neuroanesthesia. She was named as the Vice Chair for Research for the Department of Anesthesiology. Dr. Deiner was also recently named the William Leroy Garth Professor in Medical Science at the Weill School of Medicine at Dartmouth. The Vice Chair, Dr. Deiner, who currently serves as a the Garth Endowment has played an important role in stimulating research in anesthesiology at Dartmouth and Weill. As Vice Chair, Dr. Deiner, who currently serves as a Director of the American Board of Anesthesiology and will be the Chair of the ABA Research Committee, will focus on improving the Dartmouth Department of Anesthesiology research infrastructure. So thank you for joining us today. I will now begin my presentation. So thank you for being here. Thank you to the IR's group for inviting us to give this webinar. I'm going to talk about inflammation and perioperative neurocognitive disorders today. So just to give a background of perioperative neurocognitive disorders, this is a schema of the recommendations that we published in 2018 for the new nomenclature of perioperative neurocognitive disorders, trying to move away from postoperative cognitive dysfunction, which really didn't have any clinical outcomes, and the definitions and criteria were enormously varied and heterogeneous between different studies, and trying to develop a new nomenclature which was based on the DSM-5 and allows us to interpret neurocognitive disorders associated with anesthesia and surgery with cognitive disorders in the community. So we're talking about defining and identifying these disorders in the same way as patients in the community would have cognitive disorders diagnosed. That will allow us, we hope in the future, to have an understanding of what the clinical outcomes of perioperative neurocognitive disorders are, but also to understand where they fit in the overall cognitive trajectory of an older individual, because we have been looking at these disorders in a silo for over 100 years, and we really need to understand where they fit in the entire cognitive trajectory. So we're focusing really on postoperative delirium between anesthesia and surgery and hospital discharge, and then looking at delayed neurocognitive recovery and postoperative mild or major neurocognitive disorder. Our understanding at the moment of the possible pathophysiology of perioperative neurocognitive disorders is based on a more increasing amount of biomarker evidence, which is what I'm going to cover today. So we understand that surgery and anesthesia are associated with a peripheral inflammatory response. We know that in older patients, they increasingly have a leaky blood-brain barrier, but there's also a whole host of other physiological things occurring with the result of peripheral inflammation and perhaps neural pathways that lead to neuroinflammation. And it looks like, from what we can tell at the moment, that there's a downstream effect of neuronal damage from biomarker work, ultimately resulting in delirium, other perioperative neurocognitive disorders, and long-term consequences. So I'll start my talk by working through the literature to date on neuroinflammation. So this is a study that we did just recently, looking at inflammatory biomarker levels in studies that had randomized patients to propofol or sevoflurane anesthesia, and this was a meta-analysis. We looked at 21 studies that reported interleukin-6. Only 5 of those studies assessed cognition, so we were unfortunately not able to continue with an assessment of the association with cognition. But we did see that there was increases observed for interleukin-6, interleukin-10, TNF-alpha and CRP in response to general anaesthesia with either an intravenous agent such as propofol or a volatile agent such as sevo. There was no difference between those two types of general anaesthesia. And you can see here that really the IL-6 looks to be having some sort of overall effect it certainly is increasing during anesthesia and surgery. But as I say, no difference between the two types of general anesthesia. This was a recent meta-analysis as well, looking at different variety of biomarkers. 28 studies. These patients were aged 50 to 83. 12 to 52% was the incidence of postoperative delirium in the studies included, and they made sure that the studies that they included had standardized screening tools and appropriate diagnostic assessments for delirium. So you can see that there's an association between delirium and interleukin-6, CRP, S100 beta, and towards the bottom you can see neurofilament light, which shows an association with delirium. And in fact, that's a biomarker of acute brain injury, acute traumatic brain injury, and has been identified in sports players for a number of years. And I'll go through some of the evidence that we are now finding with regard to increases in neurofilament light in response to anaesthesia and surgery and delirium. This is some work by Rob Sanders' group looking at interleukin-18 in postoperative delirium. and they didn't find any association between interleukin 18 and postoperative delirium. This is an extensive study by Ian Moppet and his group, and they looked at 17 studies. They investigated 8 inflammatory biomarkers. They included cardiac, non-cardiac, and hip fracture surgeries. And you can see here that what they saw was an association that, of interleukin 6 being increased in patients who ended up suffering postoperative delirium. This is a forest plot of preoperative interleukin 6 in people without preoperative dementia, and you can see again that there's a strong association between patients who have delirium and increases in interleukin 6 and also interleukin 6 levels at baseline. So if we are seeing an association with inflammation and delirium, what are some of the possibilities of interventions that could be used that might prevent delirium from occurring via an inflammatory pathway? So this is a meta-analysis looking at dexmedetomidine and its impact on reducing delirium. 10 studies looked at dex versus placebo, and 26 looked at dex versus other sedatives. They used the CAM ICU in 23 studies. There were almost 10,000 patients. And what they found was a significant association with a reduction in delirium for patients who were treated with dexmedetomidine. They didn't find a dose effect, so it didn't seem to matter what the dose of dex was, it was just the presence or absence. This is some a further investigation looking at perioperative dex in patients undergoing cardiac surgery. This was 30 studies with just over 4,000 patients having cardiac surgery. And interestingly, what you can see here, and this is where the literature is quite controversial at the moment, is that intraoperatively, we don't see a strong association. The confidence interval is still very wide. Intra-op and post-op, similar. But when we look at ICU studies where the dex has been given just in the postoperative intensive care unit stay, we do see a reduction in delirium. So it's possibly about a dose, possibly about the time of administration, but certainly it does seem to be that in intensive care unit patients, dex does reduce the incidence of delirium. And I just wanted to highlight the heterogeneity of the intra-op group and the intra-op and post-op group, as opposed to the post-op intensive care unit group, where the heterogeneity was quite low, suggesting that this is probably a more robust result. So going back to our possible hypothesis for what the pathways are behind the mechanisms of perioperative neurocognitive disorders, I now wanted to talk about the downstream effects of neuronal damage following neuroinflammation. This is some work that we published in 2018, looking at changes in plasma neurofilament light and tau levels with anaesthesia and surgery. So these are 2 biomarkers that are reflective of neuronal damage. We know that they're increased in sports players who experience concussion, as I mentioned earlier. We also know that they're increased in neurodegenerative diseases such as Alzheimer's disease. And you can see here that the neurofilament light increased at 48 hours after surgery and was continuing to increase at that point. Tau increased at 6 hours post-induction of anaesthesia. These findings suggest that general anaesthesia may be exerting a neurotoxic effect on the central nervous system, which obviously has implications for neurological outcomes. This is some work again from Rob Sanders' group, and he looked at postoperative delirium and the increased levels of plasma neurofilament light. So a small study, only 114 patients, 71 years, and they looked at neurofilament light and inflammatory cytokines. They saw an incidence of postoperative delirium of 36%. They saw a dose-dependent association between increases in neurofilament light and delirium severity, and they saw that increases in interleukin 8 were associated with delirium. And you can see here on the right-hand side that the change in neurofilament light is quite different between, it's significantly higher in patients who went on to experience delirium versus those who did not have an episode of delirium. This is some further work, again from Rob Sanders' group, again looking at a number of different biomarkers, both Alzheimer's disease and neuronal damage biomarkers and inflammatory biomarkers. And you can see here that tau was significantly associated with delirium. So increases in tau were significantly higher in patients who went on to suffer from postoperative delirium. And this is some ROC curves from that analysis. And you can see on the bottom left-hand side that interleukin-8 showed a significant association in an ability to predict delirium. Neurofilament light wasn't so good as a predictor on the ROC curve, but there was a significant association certainly between both of those biomarkers and postoperative delirium. This is some work going back a few years looking at cerebrospinal fluid, beta amyloid and tau ratio and postoperative delirium from Zhongkong Zi's group. These patients were having hip and knee replacements. They were 63 or more years old. They had CSF drawn immediately prior to the spinal anaesthetic, and the delirium was assessed using the CAM and the MDAS on days 1 and 2. There were no pre-op delirium assessments, which is a limitation of this study. Nonetheless, there was an incidence of delirium of 20%, which is approximately what you would expect in hip and knee replacement patients. The lowest quartile of the amyloid beta 42 and tau ratio was associated with increased delirium, and the lowest quartile of the amyloid beta 40 to tau ratio was associated with increased delirium. They were also associated with a higher severity of delirium score. So again, showing that there appears to be an association between neurodegenerative disease biomarkers and postoperative delirium. So in summary, surgery and anaesthesia is associated with a significant inflammatory response. Downstream neuronal damage is reflected by increases or decreases depending on the biomarker in biomarkers for Alzheimer's disease and acute traumatic brain injury. Increases in interleukin-6 and interleukin-8 during the anaesthesia and surgery are associated with postoperative delirium. Neurofilament light increases are associated with delirium incidence and severity. It looks like dexmedetomidine may reduce delirium incidence, certainly in the intensive care unit. That appears to be the case. So further studies are needed to really assess what the timing for that intervention is going to be to reduce postoperative delirium on the ward. And biomarker levels at the preoperative stage may be useful to identify at-risk patients and implement preventive strategies. Thank you very much for your time. We will now move on to the talk from Professor David Scott.
Thank you for the introduction, and thank you for the opportunity to present at this IR's meeting. I'm going to focus today on the relationship of cognition and frailty with respect to postoperative delirium. I have no conflicts to declare. So when a patient presents for anaesthesia and surgery, particularly for a major procedure, particularly if you're elderly, one of the things front of mind is concern about postoperative confusion. And if you undertake preoperative consultations with older patients, you'll often experience questions such as, I'm concerned whether this operation is going to hurt my brain, or what's the risk that I won't be the same afterwards. And this is due to a number of factors, including experiences they may have had themselves or with other family members. So I'm going to focus on a typical patient, a 75-year-old woman who's having a total hip arthroplasty. Such a patient may well and should have an uneventful cognitive recovery, and you've seen this sort of diagram before. However, there is a high possibility that they might develop postoperative delirium, up to 60%, delayed neurocognitive recovery, or even late postoperative neurocognitive decline, up to 10% likelihood at 3 months in a patient with appropriate risk factors. So what are those risk factors? Well, for delirium and postoperative cognitive decline or delayed neurocognitive recovery, there is overlap with age and cognitive impairment. Lower IQ also predisposes due to a decreased cognitive reserve. But particularly for delirium, there are other clinical factors which are of relevance, such as the presence of comorbidities, the taking of a large number of drugs, so polypharmacy, and certain drugs such as Biomarkers drugs and drugs which have increased anticholinergic activity. And the need for sensory aid is important because particularly in the postoperative period or an unfamiliar environment where there is sedation as well, it's very hard to become oriented if you can't hear or see properly. To assess risk in a quantifiable way, we can put such a patient through a calculator like the NSQIP calculator. That will come up with a very low rate, fortunately, of serious complications, less than 10%, in patients such as this. However, some of the procedures through NSQIP now come out with a geriatric outcome, and it's quite clear from this, as we know from the data I've already presented, that postoperative delirium is a high risk. It's almost 17% in a patient such as this. So it is actually the most significant risk that this woman will face in her perioperative period. The mechanism for postoperative delirium are manifold and not fully understood. We know that surgery triggers inflammation both peripherally and if there's a leaky blood-brain barrier for many various reasons, centrally as well. And then this creates a neuroinflammatory response, which leads to neuronal injury and delirium, and potentially perioperative neurocognitive disorders as well. What I want to focus on is the predisposing factors which lead to this scenario, lead to the leaky brain, lead to the risk of delirium, with a focus on frailty. And why frailty? Frailty is becoming increasingly recognised as a relevant geriatric disorder for perioperative and postoperative outcomes. And over the last 12 years, the number of publications referring to frailty and surgery has gone up almost 30-fold. And there's also a growing interest over the last few years in the association of frailty with delirium. So the question I want to address really is, how does frailty fit into this picture of the risk factors for postoperative neurocognitive disorders and delirium? To define frailty, I think we're getting increasingly familiar with it. It's a decreased systemic reserve. It's a decreased ability to cope with stressors or change, defined as an increased vulnerability or diminished capacity to cope with external stressors and reduced physiologic reserve. And its prevalence ranges from 10 to 65%. It's higher in older orthopedic patients. It's higher in older emergency surgery patients. And it is associated with adverse health outcomes. To define frailty, there are two main models. There's the deficit accumulation model, which involves the understanding that weakness or failure or decompensation in multiple systems all add up to decreasing a person's ability overall to manage. And then there's the phenotype model, which is characterized by the way these systematic failures impact on the patient. So loss of weight, loss of strength, easy fatigability, slowness in movement, and low physical activity levels. And of course, the Freed index is the classic of those, but there are many scales which are used. And there are other scales which is being used as well, such as the biopsychosocial model. So I mentioned that geriatric syndromes are associated with poor postoperative outcomes, and these are two large studies which have looked at that. Was the meta-analysis by Watt in 2018 of 12,000 patients identified that for postoperative complication, frailty was associated with over a doubling of the risk of postoperative complications. Cognitive impairment was also associated with a 2 times risk, and depressive symptoms and smoking were also factors. However, taking these into account, this removed the relevance of age or ASA score in predicting outcome. In other words, age and ASA score overarch these things, but frailty and so forth are the factors actually which are more strongly associated with adverse outcomes. Likewise, a meta-analysis by Lin identified that frailty was associated with increased mortality even out to 5 years, and that complications, including prolonged length of stay, was associated with frailty. So frailty is a significant geriatric syndrome and impacts on postoperative recovery. How does it overlap with cognitive impairment and the stressor events which lead to perioperative cognitive disorders? Frailty itself is associated with current cognitive decline. A study of over 6,000 patients by Lebhanon identified that about 1/5, a little more than 1/5 of patients who were identified as frail also had cognitive impairment, and about 12% of patients who were identified as pre-frail had cognitive impairment. So frailty itself is associated with cognitive impairment. What's interesting is that frailty obviously is as we've defined, is a condition where systemic reserve is impaired and ability to cope with stress is impaired. It's an existing state which persists and continues to be associated with deterioration. And with respect to cognition, a large meta-analysis by Borges looked at 14,000 participants and identified that 5 years after they were assessed with frailty, they had an almost doubling of the incidence of cognitive impairment. In other words, frailty is a persistent condition which continues to create a decline in patients' health. We looked at frailty in patients having total hip joint replacements, so 300 orthopedic patients in a study which was looking at cognitive outcomes. So we did a retrospective attribution of frailty to these patients at baseline. And we identified that overall, their age was around 70. 13% of patients had frailty according to the Edmonton Frail score, and 23% had frailty according to the Geriatric Assessment Index. What was of interest was that at 3 months and at 12 months, frailty was associated with itself with increasing cognitive decline. An odds ratio of 1.5 at 3 months and a doubling of the likelihood of cognitive decline at 12 months. And that's not surprising if you consider that frailty is a chronic condition. It's persisting, and therefore decline may well accelerate over time. Further to this, looking at patients who've been screened for frailty, in another study looking at spinal surgery patients, identified that 24% of patients were frail, and looking at delirium, 25% had postoperative delirium, and the risk of delirium in frail patients was almost 6-fold that for non-frail patients having this type of surgery. And the more invasive surgery, the higher risk of postoperative delirium. In a meta-analysis, then pulling a number of these studies together, Fritz Sieber's group identified 9 studies with almost 800 patients, and a large range of frailty of 19% to 56%, in fact, a large range of delirium from 7 to 56%. So nonetheless, there was an association with frailty and postoperative delirium, over a doubling. So an odds ratio of 2.14 for frailty being associated with postoperative delirium. So there is a definite association with this. So I think we've got a clear message here that frailty should be included as a predisposing risk in and of itself for postoperative delirium. And it brings into account, obviously, comorbidities and polypharmacy, factors like that, which plug into the frailty model, whether you're using a cumulative deficits model or a phenotype model. I've also listed here some of the precipitating factors. So whilst we have predisposing factors which help us with our risk assessment of the patients, the precipitating factors are factors which we want to modify. And we don't have time to go through all of these today, but these obviously need to be emphasized, particularly in patients who we've identified at increased risk. So in summary, there are multiple tests used at the moment for the assessment of frailty. Frailty is common in older surgery patients and increasingly common the older patients are. Frailty has been identified to be associated with baseline cognitive impairment. So there is an overlap with frailty and cognitive impairment. It's not absolute, but there is a higher likelihood of cognitive impairment in a frail patient. Cognitive impairment and frailty are both associated with an increased risk of postoperative delirium and also neurocognitive decline later on. And in the constellation of the overall perioperative outcomes, delirium and frailty are associated with adverse perioperative outcomes. So I guess the final point would be that preoperative assessment of older patients should include cognition and frailty, and therefore a further discussion of risk. Thank you very much for your time.
I'd now like to welcome Dr. Stacie Deiner for her presentation. Sorry, Professor Stacie Deiner.
Thank you, Professor Everett. So let me share my slides with you. Great. So I have the fun of talking to you today about, what should you be doing in your practice to do the best that you can do to ensure that your patients wake up and have their best chance of recovery after anesthesia and surgery. So the title of my talk is Update on the ASA and PBHI is Postoperative Brain Health Initiative Clinical Practice Guidelines. So the state of the brain health consensus is actually always in evolution. I think as we get more from the literature, we integrate our understanding into practice. Although there's always a gap in between what we know from science studies and applying this to how we perform as clinicians. So the American College of Surgeons leadership has actually put out guidelines about how to best treat older adults in concert with the American Geriatric Society that are really at this point from over a decade ago. However, when we performed a survey of American Society of Anesthesiologists members to see whether they adhere to recommended practices such as screening older adults for preoperative cognitive impairment or postoperative delirium, compliance was actually fairly low. Fewer than 25% of anesthesiologists routinely talked with patients about cognition or screened patients. And so really the changes that impact patient care are not widespread out there. And I would say that not only is this sort of a negative for patient care, but it also keeps us from seeing pragmatic change in how implementation of best practices can impact how patients recover after surgery. So we strive to put together an ASA brain health consensus. So we thought that perhaps part of the problem impeding implementation by anesthesiologists is that we didn't have a consensus guideline that came out of the American Society of Anesthesiology. And in fact, the Brain Health Initiative and the American College of Surgeons work was all published in surgical journals and the Journal of American Geriatrics. And so we thought it was important for the ASA to endorse and have in an anesthesia publication a consensus statement that could help anesthesiologists think about what we should do, what they can do in their practices today. And so these recommendations are based on existing guidelines and a best practice and the best practice statements I've mentioned. We convened a panel of 22 experts, anesthesiologists, surgeons, and a neuroscientist, and performed a modified Delphi consensus process and came up with 6 fairly straightforward recommendations. And as you listen to them, while I don't think you'll find any of them surprising, I think you can challenge yourself with whether these things that we recommend are things that maybe you could be doing in your practice, even possibly tomorrow. And even if you did just 1 or 2 of them, you might make a difference for older adults. So the first is about training and education. So we said that all staff who work with older adults should be trained to identify and manage delirium in the postoperative period, in the perioperative period. So are we training our pre-op clinic staff to screen older adults for cognitive impairment? Have we worked with our recovery areas to identify patients who are having a difficult time reorienting after surgery? And not just those patients who are trying to climb out of bed, but even those who are sitting there quietly confused. Have we been working with them with what sort of basic measures they can take to understand and ameliorate those cases of early delirium? Our next recommendation is about preoperative cognitive screening. And we said all patients who are greater than 65 years of age should receive baseline cognitive screening. That actually is a little bit younger than the American College of Surgeons recommendation, which is 75 and older. I think that this recommendation acknowledges the fact that cognitive impairment and frailty, as the two previous speakers mentioned, is actually more common in older surgical patients than it is in community dwelling older adults. And so possibly screening younger people may be higher yield in our surgical population. And we recommend that anesthesiologists and perioperative providers should use simple screening tests which are suited to our busy environments and to people who don't do cognitive assessment as a living. So the most widely published test used in the perioperative period is the mini-cog, but people have also published using the MOCA and other things like the short blessed test. There's a very nice review of use of preoperative screening tests for older adult by Kate Price's group that is a beautiful summary on this topic. Postoperative delirium screening should be performed on all older adults greater than 65 years old before they leave the recovery room. I think that the jury's still out whether emergence, agitation, and confusion is the same thing as postoperative delirium, but there's definitely been shown to be an association between patients who have issues with reorienting in the recovery room and those who go on to have problems in the postoperative area. And so it really is worthwhile to screen older adults for confusion and delirium before they leave the recovery room to make sure that we're communicating with other providers about patients who are starting to develop a problem, but also to make sure that we're looking into any reversible and treatable causes and any potentially dangerous causes of postoperative delirium. So examples of screens that have been used in the recovery room include the NuDesk, which is a nursing scale, the 4AT, which is really fast, and my group has actually built an Epic-based version of this, and also the BCAM. Our next recommendation is using non-pharmacologic interventions to prevent delirium. So the entire perioperative care team should deliver proven non-pharmacologic intervention to older surgical patients. And so these include encouraging ambulation, orientation, engaging in physical therapy, and also the rapid return of glasses, dentures, and hearing aids. And so one example of a way that we've accomplished the rapid return of these devices in our environment at Dartmouth-Hitchcock is that we instituted a bright yellow cardboard box that patients get when they come into the hospital, and that's for their glasses, hearing aids, and dentures. And that box travels with them throughout their stay. So it actually goes with them to the OR and goes with them to the recovery room. It's bright yellow, it has their name on it, it's very hard to lose. And it's a visual cue to actually give those sensory aids back right away. And we've been very successful in increasing how often patients get their sensory aids back immediately after surgery. Pain control. We recommend that anesthesiologists and surgeons work together to optimize pain control. You want to prioritize minimally sedating medications and use a multimodal approach. Of course, the devil is in the details. Both poorly controlled pain and control of pain with large doses of opioid, but also non-opioid medication, is associated with postoperative delirium. And so finding the balance where you're using medications that are not contraindicated in older adults, like gabapentin and ketamine, to make sure that you keep patients from having poorly controlled pain is a bit of a dance. And so, if you're identifying patients prior to surgery who are at risk of severe pain afterwards, either because of the procedure or because they use opioid medications prior to surgery, it's really worth making a proactive plan where you think about whether the patient could benefit from say, neuraxial blocks or peripheral nerve blocks, or working with your pain specialists in your institution to have a proactive plan so that you're not stuck with the case that the patient is delirious in terrible pain and now you're trying to rescue them. We also recommend treating delirium without antipsychotic drugs as a first line. So physicians generally should not use antipsychotic drugs, and especially not use benzodiazepine to treat delirium. You want to start by using family members to help with reorientation, and you want to do a very aggressive look for treatable factors. A very common cause of postoperative delirium is that older adults sometimes receive scopolamine patches or other polypharmacy such as gabapentin to try and prevent postoperative nausea, vomiting, or enhance their recovery, or do a multimodal pain approach. Older adults are much more likely to experience postoperative delirium than postoperative nausea and vomiting. And so things like anticholinergic medications, which cross the blood-brain barrier, are really a terrible scourge in older adults. And so if you find a scopolamine patch on an older adult who's confused, you really want to take that off right away. Antipsychotic drugs really should only be used as a rescue if a patient is at risk of harming themselves or the staff around them and reorientation measures fail. And then they should only be used at the lowest possible dose. Benzodiazepines are almost never the answer. A confusing situation here is when patients are in the middle of alcohol withdrawal, and then you're really going to need to work with some specialists to come up with the best plan for that older adult. There are several areas where there's lack of consensus, where we really wish we had better information to offer you. Processed EEG and what you should be doing to avoid postoperative delirium is not entirely clear. Certainly, it seems fairly obvious that inadequate planes of anesthesia, where people are so light and they're tachycardic and potentially in pain, are bad. But it also seems that people who have experienced large amounts of burst suppression probably have more episodes of delirium. And so I think you want to avoid inadequate but also inappropriately deep planes of anesthesia, but exactly what you need to do has not been fully delineated. There's no single best intraoperative medication anesthetic regimen to prevent delirium. So I saw a question in the chat already that had to do with IV anesthetics compared with gas. And so there's no good evidence that IV anesthetics prevent postoperative delirium as compared to anesthetic gases. In terms of the management of blood pressure, I don't think we have exact thresholds. There's some really important work being done on individual thresholds using things like cerebral oximetry to understand individuals' need for blood pressure. And there's a very nice POCI consensus guideline that talks about probably that lower limits of blood pressure are probably higher than we were taught many years ago to prevent postoperative delirium. There's not fantastic guidelines for enhanced recovery for older adults, and I would be very excited to see some large pragmatic trials of enhanced recovery programs for older surgical patients. They're definitely very much needed. And I think the previous speaker did a nice job of talking about the fact that there's an association between delirium and frailty. Whether frailty can predict delirium or frailty is a surrogate for something else is a little less clear, but certainly for the purpose of talking to older adults who are frail, it's probably worth telling them that they're at higher risk of confusion after surgery, although frailty alone probably is not enough to just predict delirium. And the role of preoperative cognitive impairment certainly cannot be discounted. For processed EEG, we the reason we don't have great information is the trials which achieved separation of anesthetic dosing found effect to reduce delirium, and trials which didn't find separation found no effect. And so, and longer-term cognitive outcomes have even less clear information. There's still a lot of room in terms of intraoperative medication research. We really could use a modern day study that compares regional nerve blocks instead of just neuraxial versus general anesthesia. What blood pressure is safe for older adults? There's evidence for harm for systolic pressures less than 90. We think it could be even higher for hypertensive patients. And the current recommendation is to maintain systolic blood pressures of greater than 60 and less than 160, or greater than 70% of the preoperative baseline. And that's probably pretty conservative. One last thing I wanted to touch on is the idea of consenting patients. I think our survey suggested that very few anesthesiologists are talking to older adults about delirium in the brain after anesthesia. But the Institute for Healthcare Improvement, Age-Friendly Health Systems strive for the 4 M's. And for older adults, that's what matters most to them: medication, mentation, and mobility. Older adults are very sensitive about the fact that their cognition could be off or impacted after anesthesia and surgery. We really strongly recommend discussing the possibility of postoperative delirium. Please remember that it's the most common complication for older adults after surgery, much more common than even chipping people's tooth, and certainly more common than heart attack, stroke, and death. And the earlier you discuss it, the better. I mean, ideally, you would talk about it when the patient was booked for surgery and consulted, but even if you're talking to patients right before surgery, it's important to start getting comfortable with talking to patients about brain health. And if you have questions, the ASA Brain Health Initiative has some literature on our website about talking to patients about brain health to help you feel more comfortable. So future directions, I see that the role of anesthesiologists could be expanded, and we need to think about our role in the larger perioperative medicine team. I think we can improve our education and communication about delirium. I think we can do a much better job consenting patients, older adults, for the things that are most likely, like postoperative delirium. I think we can be more proactive to identify geriatric specific risk factors and identify delirium early. And I think we can all become more comfortable with non-pharmacologic delirium prevention and being part of the solution to make sure that older adults get their best chance to recover as well as they can. So thank you to the ASA team that supports the Brain Health Initiative, to Dartmouth-Hitchcock, and to my chair, who makes sure I get the time to do the work that I do. And many thanks to Dr. Everett, who put this panel together today.
Thank you so much. That was a really great talk and a great update on the current guidelines. So we have a few questions. I did want to say that if we don't get through all of the questions, please feel free to email and ask questions if they're not all answered before the end of this session. So the first question, do you have a control group that didn't go through surgery to discern between inflammation created by surgery versus the effect of general anesthesia? And so the answer to that is really comes back to your study, Professor Deiner. Maybe you'd like to talk to that about your biomarker study.
Yeah, so it's always fun to share the stage with Dr. Everett, but one of the fun things is that my group did a study where we actually looked at biomarkers in patients who had anesthesia and didn't have surgery. And so we actually did not find a rise in inflammatory biomarkers or tau or neurofilament light in patients who had just anesthesia and not surgery. These were healthy volunteers.
Fantastic, thank you. So earlier in one of the IR seminars, there was data presented about the effect of SIVO versus desflurane on the developing brain. In the young mouse, the tau protein was induced by SIVO, but not by des. Firstly, I'm not an expert in pediatric neurotoxicity by any stretch of the imagination. In terms of the difference between SIVO and DES, I'm not aware of that's the seminar where that data was presented. And differences in delirium post-op by looking at the type of volatile used. All of our patients, and certainly in my Melbourne centre, all of the patients receive SIVO. It would be very rare for a patient to receive desflurane in our institution in Melbourne. And my understanding is that that's pretty rarely used now due to the environmental effects. I don't know if you have anything to add to that, Dr. Deiner.
Yeah, we pretty much don't use sevoflurane. You only use sevoflurane. Almost never use desflurane. Similarly about environmental effects. I don't know of, I want to say Colin Royce might have done a desflurane study, but there's certainly not a lot of comparison.
No. Thank you. Does the use of dexamethasone reduce inflammatory response and delirium? So there's only a couple of studies that I'm familiar with that have actually looked at dexamethasone, and there's nothing startling that suggests that that would be a useful agent, even though intuitively you would think that it might be.
I would add that sometimes it's timing. You know, it may be that giving a single dose of intraoperative dexamethasone doesn't really do much to the larger inflammatory response that continues on after surgery's over.
Yeah, and that brings up an important point that Mervyn Mazzy does a lot of work looking at the resolution of inflammation in animal models, and looking at the hypothesis that in fact it's not necessarily the inflammation itself, but perhaps the problem with resolving the inflammation and ending up with chronic inflammation that could be part of this story. What is the relationship between delirium and non-opioid anesthesia? I'm not familiar with any particular studies that have looked at that. Are you familiar with any, Dr. Deiner?
Yeah, I don't think there are any studies that have compared people getting like zero opioid with people who have gotten opioid-based anesthetics. I mean, there are ones where they've looked at different methods to reduce the amount of opioids. So they've given people, say, doses of gabapentin. There's also studies where they've looked at ketamine, and that actually neither area of investigation has successfully reduced the amount of postoperative delirium. I would say it's always a little tricky. You know, I wouldn't tell people to just start, throw out all the opioids for older adults, because a lot of the drugs we use instead are on the Beers list and have some pretty significant side effects for older adults. So you want to be careful about that.
Yeah. The first speaker added the new acronym PND as opposed to POCD. Any reason? So the reason for that is harks back to the 2018 paper, which was the new recommendations for new nomenclature for perioperative cognitive disorders. And the main reason behind that, I apologise if I wasn't clear when I discussed that slide, but really is to use definitions and criteria that are consistent with the diagnosis of cognitive disorders in the community. When we used the term postoperative cognitive dysfunction, it was so heterogeneous in terms of the way it was assessed. we rarely had control groups, and we didn't have any functional outcomes. We didn't look at subjective impairment, and that's incredibly different to how cognitive disorders are diagnosed in the community. And what we felt was really important was that we align what we see perioperatively with how cognitive disorders are diagnosed in the community, so that we can have an understanding of what they mean for the overall health of an older individual. Please feel free to email me if I haven't explained that adequately. Frailty and nutrition index parameter can affect cognitive impairment. Absolutely. Is there any idea? Not a lot. It's really interesting that you bring that up. Certainly, we're undertaking a multi-component intervention study in Melbourne, looking at several factors, and that includes nutrition. And we spend quite a bit of time preoperatively trying to improve patients' nutrition, and in the perioperative period and postoperatively, and a lot of education about lifestyle factors. I'm not familiar with any other component interventions that have specifically looked at nutrition and cognitive outcomes or delirium, but I know that there's a lot of evidence about nutrition and overall outcomes, complications, particularly in fractured neck of femur patients who end up, they can be fasted and cancelled and fasted and cancelled and fasted and cancelled, and that can be very detrimental. Anything to add?
Yeah, I think that people have written about nutrition and frailty, but I don't know that they've looked at whether you can use nutrition to sort of break the link in between frailty and delirium. And I think we still haven't worked out what is the mediating factor, what is the way by which frailty causes delirium. Some frailty indices also have cognitive screens in them. So it does look like, even in studies, if you take the cognitive piece out, frailty is still independently associated with delirium. But how has not yet been worked out.
Yeah. Back to biomarkers. Often studies look at one time point. The question is it the production or the clearance of the given biomarker level that is affected? That is a great question. I don't know the answer to that question. We certainly have published sequential biomarkers. I agree that there's a serious limitation to studies that only do one postoperative biomarker, in particular because we know that different biomarkers peak at different times postoperatively. That said, it's obviously incredibly demanding and resource intensive to take multiple biomarker samples postoperatively. But I do think that until we have a much clearer idea of what the trajectory of each biomarker is, we can't manage with just one postoperative assessment. And with regards to production or clearance, I don't have an answer. Dr. Deiner?
Yeah, I would say that there's some really cool work done by Basu-Nildeshorn.
Oh, yes.
And yeah, that has to do with inflammation and delirium. So the SAGES data set did a really nice job of collecting inflammatory biomarkers. And she came up with a really cool way of conceptualizing them, which is that some biomarkers are better at predicting people who will become delirious, and others seem to be markers of delirium severity. And so I would point anyone who is interested toward that work. But even that super clear work where they did these high delirium resolution, even that are fairly small numbers, and I think there's still room for much more work in that area. But I'd say the relationship is fairly clear.
Can I use pre-medication pregabalin? Is there any relation without delirium, with delirium? I'm not aware of an association, a direct association, or any study that has looked at a randomized study that has looked at that. But I would say that most people that I'm aware of would suggest that you would avoid pre-med of pregabalin in an older individual who was at risk of cognitive impairment or delirium.
Well, and especially nowadays when we're sending people home, if you're thinking about, gabapentin and gabapentinoid type stuff, these make people fairly dizzy. So you want to think very carefully about loading people up on medications that may make them less safe to go home.
I've just been told we don't have a hard stop, so we will just continue. There's just a couple more questions. Thank you very much for the excellent lectures. Assessing delayed neurocognitive recovery is difficult as the patients return to the hospital for follow-up surgical visit more than 4 weeks after surgery. I do understand that. When would you recommend assessing postoperative neurocognitive disorder? So I would say most studies assess postoperative neurocognitive disorder somewhere between 6 weeks and 3 months, and then around 12 months. With regard to delayed neurocognitive recovery, it is difficult, but some of the information that feeds into that is even a follow-up phone call at 30 days to look at any complications, any readmissions. So I think although it might be difficult to assess for delayed neurocognitive recovery at the appropriate time at 30 days or up to 30 days, there still is some information we can gather without having to have a face-to-face with the patient. But with regard to postoperative neurocognitive disorder, most studies would say 6 weeks to 3 months and 12 months. But we do have to do longer studies as well. We have to go beyond 12 months and look at continuing diagnoses and new diagnoses and what that means in the temporal association. Concerning blood pressure recommendations, isn't the low blood pressure more a sign of a problem, low cardiac output, than the problem itself? And as far as I know, there are only studies showing association, no studies that could really show causation. Dr. Deiner?
Well, I would say that Charlie Brown's doing some really nice work looking at things like cerebral oximetry. I mean, really, we're using blood pressure as sort of a surrogate for adequate perfusion for the brain. And that's fairly individualized, and it has to do with how high your blood pressure was before and possibly anatomic things and your responsiveness to vasopressors. And so I think that the next 5 or 10 years, as Charlie does more work, he and other people may work out some really great things that actually look at things like tissue oxygenation and the phenotype of cognitive dysfunction. And I think that will be a much more final word. I think the current studies on blood pressure and cognition are probably not fully adequate.
When we look at ICU patients, there is about a 20% incidence of patients who develop inflammation syndrome. Is it possible that this abnormal response can be found in a 10 to 20% of the surgical patients as well, and that those patients are generally predisposed to an abnormal inflammatory response, such as we see in COVID patients, in response to more to the surgical stress than to the type of anesthesia? Well, I would definitely, and I would say that at the moment, the information that we have or the literature that we have to date suggests that it's much more likely that it's a response to surgical stress than a response to anaesthetic agents. There is very limited evidence that anaesthetic agents make a difference. So I would agree with that comment, but Dr. Deiner?
Yeah, the evidence of one anesthetic is better than another is pretty limited. And just to step back and give you sort of a larger perspective, I mean, relatively speaking, our anesthetics are extremely safe nowadays, and the couple of hours that we have people under anesthesia is usually vanishingly small compared to the lifetime they've spent before we anesthetize them with poorly controlled high blood pressure, diabetes, plus minus drugs, smoking, hyperglycemia, etc. So I think it's very unlikely that anesthetics are a large part of what happens to someone's brain after surgery. They might make a small difference for some vulnerable people, but I doubt they're the driving factor for the large phenomenon we're seeing.
Yeah. Professor Everard, you pointed out that not assessing delirium in the preoperative period is a study limitation. Why should one consider assessing delirium before elective surgery? Because surprisingly, some patients do actually meet criteria for delirium preoperatively. Very few, but nonetheless, some do. But more importantly than that, many patients actually will have one feature. And we can't really assess postoperative delirium if we don't know whether that feature was present preoperatively. For example, in the 3D CAM, which is a structured assessment for delirium, which is commonly used in research projects, one of the questions is months of the year backwards. There are quite a few people who just cannot do that, even preoperatively, and we need to really know that so that we don't attribute that to the as a postoperative change. The other thing is that subsyndromal delirium is increasingly becoming known to be a risk factor for longer term decline, just as the full-blown delirium is. So having the information about whether there might have been one or two features preoperatively is actually important information for interpreting any postoperative changes. Has the fog buster caffeine been used in both caffeine naive and tolerant patients? I'm not aware of anything. Is there any association between the appearance of burst suppressions on the BIS monitor and dementia? That's a terrific question. And in fact, there's an association between burst suppression and delirium. There's an association between delirium and progression to dementia. But as far as I'm aware, there are no studies, no longitudinal studies that have currently looked at burst suppression and longer term progression to dementia. Have biomarkers been assessed in healthy geriatric patients? Oh, this is, I guess we've answered that question with your study, Dr. Deiner. Awakening after anaesthesia is passive at this point, and it's unclear why we are not using stimulants that even neonates receive. Thoughts? I'm going to hand that over to you, Dr. Deiner.
I think there are a couple of small studies of stimulants, and to my knowledge, they have not shown a positive effect. I mean, I think in older adults compared to neonates, you might be worried about some of the side effects of stimulants, such as hypertension, tachycardia. I'm not sure that would be safe.
There's one last question in the chat. Any correlation between type of surgery or regional anaesthesia? No, it doesn't appear that there's a difference between regional versus general or intravenous versus volatile anaesthetics. But as Dr. Deiner mentioned in her talk, there really hasn't been a definitive study of either of those to answer either of those questions. Would you like to add anything, Dr. Deiner?
No.
Okay, I think that brings us to the end of our questions. If I have overlooked anything, I apologise. Please feel free to email any of us or jump on the IR's Docs Matters conversation online. Thank you so much to everyone for your attendance and for staying after to have this great Q&A discussion. And thank you so much to the IRs for organising this webinar, and to Professor Deiner and Professor Scott for joining me to do this session. Thank you so much.
Thank you, Dr. Evelyn.